Welcome to the Pulse of Change. I'm Dr. Abdulelah Alhawsawi.
And I'm Dr. Azhar Ali. Welcome to the Pulse of Change. In today's episode, we're going to be exploring how population health and innovation can be leveraged to improve health outcomes. And so we have a wonderful guest today, Dr. Dominique Allwood, who's the CEO of Imperial College Health Partners, which is a health innovation network for the northwest of London. And Health Innovation Network, we'll talk more about Health Innovation Networks, so essentially at the intersection of academia and the NHS. This network covers a population of 3 million in London. And Dominique's also a public health physician by background with 20 years of experience working both in the UK and internationally in leadership and management. Also, I think, Dominique, you've been honored recently as an MBE by the King in the New Year's Honours List, and that's a reflection of your work and dedication. So, Dominique, welcome to the Pulse of Change.
Thanks so much for having me here. I'm really looking forward to the discussion, and thanks for the very generous introduction. I'm looking forward to sharing insights with you both.
Thank you very much. And, population health and innovation, these are, I think, really important topics. But maybe before we dig in and dive into some of those areas, you could maybe tell us a bit about yourself, your background. How did you get to where you are, and why did you choose the position you're in now?
So it's, I guess, a journey that goes back about 25 years. I was studying medicine, so I'm a doctor by background. And I remember thinking as I was looking down microscopes and looking at very small details that you do when you're learning about medicine, that I was very interested in understanding the bigger picture of healthcare, how things work, why patients get sick, how they turn up in our health systems, and how they sort of navigate their way through. So I was always thinking as I was training to be a doctor, which part of the ology or specialties is the thing that focuses on the bigger picture of healthcare? And I discovered public health, and I learned more about it actually away from the NHS. I trained in the NHS in the UK, but I also went and worked in New Zealand, and there I spent a lot of time understanding what does population health mean, how do we work with indigenous and local populations to understand specific health needs, and that made me really get interested in public health and population health. And I came back to finish my clinical training as a doctor, and I soon realized that there were lots of parts of the system that were not working well, and we would see the same patients coming in through the ED, and I thought there must be a different way of focusing on care and thinking about some of those upstream changes, and also how do we deliver care to be the best that it can be. So I got very interested in both public health and population health. So I guess decisions made sort of far from the bedside shape the outcomes for people and patients, and I wanted to understand more about that. But I also wanted to focus on the role of healthcare in doing that. And I spent some time working across lots of different types of organisations, both within the UK and internationally, around healthcare delivery, around policy and national ministry type organisations, in academia, in thought leadership. And I guess what's been really consistent in what I've wanted to do is a desire to move from, I guess, looking at problems and understanding insights to really thinking about impact. And that's taken me really into the role now that I have, which is at the intersection of population health, innovation, and systems leadership. So as you say, I run an organisation that's an innovation partnership. Imperial College Health Partners works very closely with Imperial College and some brilliant hospital groups in northwest London, really trying to tackle those problems that we face in health and care, where there's a real place for innovation and evidence and delivery to come together at scale.
So how has your background then influenced how you look at population health and innovation, and the way you kind of deal with things that you're trying to do in the network?
So I think what public health does is it trains you to think more long term. And so in some settings, you can find that when you're looking at resourcing or funding interventions or improvements or change or innovation, that we can think a bit short term about when are we going to see a return for that investment. And public health trains you to think, well, if we really want to impact on health, we've got to think in the longer term. We also need to think about taking a more systemic view of the issue. So it's not just the problem in front of us, but all the things that are relevant before and after that we see that problem. So you take a more system-wide approach. So that's been sort of very helpful in helping me think about how do you understand systems? How do you understand what it takes to make complex change work. But I guess my work in the NHS and in healthcare delivery organisations has really grounded me in reality, because the first part of what I've just said could sound quite theoretical and abstract, but I'm very focused on sort of what actually changes in practice. How do you change behaviour of both healthcare professionals and systems, but also patients and the public, to really improve those outcomes? So it's not just about on paper or in theory what good looks like. It's about actually making that happen. And then I guess innovation more recently has come into the work that I do. I started in quality improvement, so some of that more incremental and continuous change, and have now moved more into the larger scale, potentially more disruptive innovations. But all of that only really matters if we're improving health and people's lives and improving the systems we work in.
And I think you're also, as well as your role in the network, you're also Director of Population Health in the NHS Trust, Imperial College Healthcare NHS Trust. So is that where you get to then try and apply some of those things, or how does it work?
Yeah, it's a lovely portfolio. So I spend the majority of my working week at Imperial College Health Partners. So we are an organisation that is a partnership organisation of the hospitals, of the academic institutions, and we work also with commercial and industry and innovators to deliver innovation and improvement. And we do some implementation support, but we're mainly that partner, the collaborator and the convener in that role. And we sit in that sort of system place to enable those partners to do that work really well. But I have this other role that I work in a hospital, every week. I'm sitting here right now in a hospital, in a nurse's building, where I use my public health and population health skills and my change background to help our organisation really fulfil its role in improving health. So how do we help people stop smoking, for example? How do we think about people's weight and mental health? How do we think about our role in the community to improve health and access to care? And so that's more on the sort of delivery side. So I really like doing some of the more, I guess, planning and collaboration and design work, but I'm also in my role right now sitting in a building in an organisation where we have to actually drive impact. So it's a great portfolio.
Great. So let me dig in a bit deeper into the whole area of population health. So, you're a public health physician back. You've talked about public health. We hear people talk about population health management, both in the UK and the US and even in the region here. Population. So what do you see as the difference between public health, population health, and population health management? Are these all the same thing? Are they different things? Are people using them interchangeably? Can you give us a bit of an explanation on that?
I think the answer is it's both. So they all are distinct in their own ways. I come from a public health, which is a field and a way of practicing. And we talk about the art and science of improving health, which is a public health approach, which really starts with taking a lot of the evidence and methods, but it also is about understanding needs and context and thinking about how you really craft and make those interventions very local and creative to what is needed. So that public health is the sort of specialty in which I've trained, and many people work in the field of public health. We've got disease, communicable disease control. We think about the role of local government. That's a lot of what public health does. But I think it's very linked to population health management, and population health improvement, because at the core of all of that, I guess, if you take a sort of start with the end in mind, what we're trying to do is improve physical and mental health outcomes and well-being of people. And then some of those different nuances are about the scale and level at which we do that, whether that's local, regional or national, and how far at that remit it expands out into addressing also some of the broader social determinants of health, like housing or community factors or work. And I think there are different ways in. So population health management is about taking a defined group of people, grouping them by need, so stratifying them and saying, how are you similar to other people like you, and therefore what are the interventions, the services or the resources that we need to plan to deliver to help manage your health for people that look like you. Whereas I think population health improvement is a bit different. That's about starting with, well, what are we trying to get to in the way of improvement, and what are the methods that are going to be there? So we've now got segments of those people. This isn't just about measuring endless data. This is then about taking things like quality improvement methods that many people are trained in and know and use, to then bring in, how do we work with patients and communities? What are the methods that bring our clinicians and other staff alongside us? What are we trying to achieve? How will we know we're getting there? How are we going to get there? How are we going to measure things over time? So all of these concepts are different, but I think the thing that holds them all together is the outcome, which is about improving physical and mental health outcomes and well-being for people in defined groups. So I would keep it simple. I think people get maybe overly exercised about all of those differences, and I think labels are a bit unhelpful, to be honest.
Sure. So can you take us a bit more into, the practical aspects of, if we say population health, moving from a concept to give us some idea of, what does it look like? We're talking about population health improvement. How does this look like practically? What are the things that you're working on maybe in your current place, or you've seen that are successful, and what's going to have an impact on health outcomes?
So I think the first thing, if you come from more of a healthcare background, or you're working in a more of a healthcare focused role, it's a shift that starts with, instead of saying how good is the service we're providing, starts to say how healthy are the people that are in our communities or using those services, and what can we do to help improve that health. So it starts not from the delivery of the service perspective, it starts from the people or the population perspective. And then we want to look at how healthy people are, how long they're living, are there gaps in their health and the way in which they use healthcare, etc. So the practical steps really are to identify those populations that you're working with, whatever scale of the system, whether you're in a national role or a very local role. What populations are you talking about? Using data that includes quantitative data, so counting things about the population and the use of their services, but it also requires us to go out to those people and understand insights from their perspective, to see what are the barriers they're facing in terms of their health or their healthcare challenges. And that requires co-production and development in partnership with people. And so I think I've got a lot of examples of where we've done that, both from a healthcare perspective and beyond. So, for example, we were trying to understand in our hospital, who are the patients that keep not attending for their hospital appointments? These are often things where 10 to 20% in the NHS of patients don't come for an appointment. And in any healthcare system, whether you're publicly funded, privately funded, insurance funded, whatever the funding model, you're trying to make good use of your resource. And if patients aren't coming for scheduled appointments, that's not good value for the system. And there's clearly something going on where those people are not then going to get the treatment that they need. So we then took an approach of saying, well, instead of taking a service perspective, let's look at characteristics of those patients and understand about language or some other concepts or data that we could look at, to then go and say, well, let's go and speak to those patients and ask what's going on. Why is it you're facing barriers or challenges? And so that's one example of, I guess, looking at the lens of access and why people may not be coming for their appointment. But there are huge amounts of other ones. We've done a lot of work in our services to understand people who are struggling with poverty or poor housing, or some of those bigger picture things, and how we can have an impact through healthcare. I think there's some really easy and quick wins we can do. We have a huge evidence base around things like the importance of trying to help people reduce and tackle smoking. And we know the impact that has on health, but we don't always do that very well. So there's something about, how do you take something where there's an evidence base for it and really turn that into action to try and improve health? Or, for example, vaccinations, huge unequivocal evidence for the importance of things like childhood immunizations, but we know those rates are changing and declining. So how do we start with the populations that really are struggling with those interventions, and understand from their perspective what are the barriers and issues, and how might we support them, and then apply improvement methods? So what does good look like? What are the interventions that are going to make a difference? And then start to measure those. So I've got lots of examples of how we've tried to improve population health from a sort of service perspective. But I think it really starts with, who are the populations that we're worrying about, and then what can we do?
Dominique, you mentioned something very interesting, which is co-production. Historically, healthcare systems have been built in, this paternalistic approach where It is, as healthcare providers, it's what we do to to patients at the hospital, and then what we do to the population that we serve at large. But I really believe that co-production is going to be the key for sustainability. Can you dig a little bit deeper in co-production? You mentioned because non-communicable disease is a huge burden for not just high income countries but even low and middle income countries. So can you address that a little bit and maybe talk about the how health literacy and how patients and population in empowerment and engagement is going to be helping with the sustainability of healthcare systems?
I think you touch on such an important point. We can get sort of caught up in, from the system perspective, what is it we need to do as systems? And really the system is only made up of the people that use it, and how we understand their perspectives in the way in which we design and deliver our services and the interventions is really important. And as you say, co-production is a very important part of that. That goes beyond seeking feedback, that people tick smiley faces or boxes and say the service was good today or it wasn't, and that that's feedback. Or even consultation, which is how well do you think we've done, or what do you think about this thing we're proposing? Whereas co-production really starts with, we're equal partners here to try and understand the problems and tackle them together. And whether that is in an individual consultation with a patient, co-producing a plan and understanding someone's goals, all the way through to big systematic redesign of healthcare, or trying to tackle a huge problem like a decline in the MMR vaccine uptake, and think about which people need to be involved in understanding and planning those improvements. It's so important to have the voice of not only the staff, the clinicians and healthcare providers, but very much them, but very much the patients and the communities, the citizens and residents who really we're talking about. And as you say, without that, it takes a very sort of paternalistic view, a done-to view. And we know that evidence shows that if you involve people in decisions about their care, whatever level that is, and in their health, that improves their interest in it, their ability to understand it, and their onward commitment to wanting to make things better and change, whether that's adherence or compliance to their own healthcare interventions, or indeed staying engaged with work that is often large-scale, complex transformation. So there's a huge amount of evidence to show it's important. It's very hard to do it well and meaningfully and not get too reductionist around, well, I need a tick box of this type of set of people, so I'll get 3 people from here, and then if some other group's underrepresented, so I need to go and find 1 person from there, and end up with sort of quotas. We need to do it meaningfully, so these views are drawn from a wide section of people that we are interested in. But we've got to remember that people can't represent each other. So, if you as an organisation have got 1 person with lived experience on your steering group, and you congratulate yourself that you're doing, good involvement or engagement or co-production, that person can't speak on behalf of many other people. So how do you make sure that you are inclusive and broad and proportionate in the people that you involve? Yeah, I always think it's a shame when we only ever have like this ratio of like 20-1 where we have someone with a lived experience in the room talking, because actually if we really value that experience, we need to have more people at the table having that conversation. But as you say, it's very important in relation to health literacy, people understanding about their own conditions and having the skills, the capability, the agency to be able to do something about that. And we've got to do a lot of work as much as we can to support people. You mentioned communicable diseases and non-communicable diseases. We've got the big challenges around long-term conditions and how people look after their health, as well as, the things relating to infection, etc. I think at the heart of all of that, though, is that health literacy and the co-production element of really thinking that we're partners in how we do this work together.
Great. So we're going to switch gears and talk about innovation, and I'm going to look at it from a macro perspective, going all the way down to meso and micro. So we talk a lot about innovation, but most health systems are still stuck in a pilot culture, quote unquote quick wins, rather than transformational culture. So in your experience, what is the difference between, the systems that experiment with innovation and systems that actually institutionalize innovation?
Wow, that's a great and a big question, and very relevant for me at the moment. So I'm leading this innovation partnership, and what we've found and learned over the last few years about how to make innovation really, I guess, stick and embed and scale. One of the things we've done is take a mission-based approach to innovation. So thinking about a bigger goal that crosses a large number of people or organizations across a system that not one individual entity can solve on their own, that we do for longer and we do fewer things to focus on this mission. And we've got a number of missions around improving people's health through cardiovascular disease and thinking about how we reduce strokes and heart attacks, or reducing the morbidity that comes with mental health crisis. So big missions that we're thinking about around how do we improve the health of people in our sector across 2.4 million people. We've taken an approach that says to do that, we need to start with the end in mind, which is think about the scale of people that need to be involved in that. And of course, we often do need to do a pilot that says, let's take something where we maybe don't know the evidence exists, or we do know the evidence exists, but we don't quite know how to then embed it. Before we spread it wide, we start small, make sure it works, and then start to scale up. But I think that that's sometimes a mistake in innovation, because we can, as you say, get very caught in this sort of pilotitis loop, which is just keep doing a whole number of small things that never really scale. And recently I got the privilege to write a blog about thinking about how you implement technology, which is often more disruptive and is in the bucket of innovation. And we've thought about it through a different lens, which is to start with instead of a crawl, walk, run, which is sort of, expand your pilot into bigger, more systematic places, but do that through a very phased approach of small and then slightly bigger, etc. We've started thinking about some of our innovation through a sort of run, walk, crawl view, which is you have to sometimes go a bit bigger bang to get traction and energy and insight and engagement, and start with larger numbers of people to make sure that you really understand that the change is making a difference and that you can prove it at scale to be able to then get it to sustain. So I think really, I guess what I would say to this is the biggest mistake often is that we start with thinking that the pilot is the goal, whereas we need to design the scale in from the start. And that means aligning the innovation to the priorities of the people and really using them to draw in what are the problems we're trying to solve, so that we're not just coming up with solutions that then we retrofit a problem, that we align to system priorities, that we involve people early, and that we build in the evidence base that decision makers really need, but that crucially that we're planning for adoption scale, not planning just for the pilot. So the end is not just the evaluation of the pilot. And we're trying really at ICHP to think about how we make that routine, not just something that sits alongside the day job. So that would be, I guess, some of the learning we've had through the mission work that we've done. You've got to have that leadership. You've got to have that intention at the beginning that people really think, if this is a better, more effective or cost-effective way of doing things that will tackle our problems, then we need to be able to commit to say we will then flip into doing this, and we will do it at scale and pace.
Amazing. So now moving from the macro to the kind of meso micro, and I'm very intentional on using these terms because during my time in the Saudi Patient Safety Center, we often recruited from individuals that only worked within a hospital, so they're familiar with the micro, and I think you can speak to that you've moved from being a doctor, a physician, into kind of a public level, which is I keep telling people what got you here will not get you there, because it's kind of a different way to address it. So it is very important for listeners and for audience and people that work within healthcare systems to know where you are and what you're trying to achieve, and if you're trying to fix a macro problem with a micro tool, you're going to be frustrated. So going into that, what I want to ask you is, a co-production, but from a different angle. This is a co-production between the macro kind of national level, leaders and the clinical leaders. So many innovations fail because they are designed for clinicians, not designed with clinicians. So what distinguishes, from your perspective, the systems that use the former versus the latter? Can you speak to that? And I think, again, you have a very rich experience and, coming from working at a micro and then working at a macro, but then you're also working in this intersection between innovation, public health. So how can we make sure that we, many healthcare systems are undergoing a transformation. We're undergoing a massive transformation here in Saudi Arabia. And I think you talk to many clinicians and they feel that they're not aware of what's going on. Many things are kind of just being done to them rather than being done with them. And how can we bridge that gap?
Well, it's a great question. And I think, the best systems, as you say, around the world have very high clinical engagement and often are clinically led as well, because clinicians are very close to those problems and they recognize where the frictions are and what won't work. So I think the issues have to be grounded in the reality for people. And the role of then system leaders is to, I guess, support and create that infrastructure so that those are the problems that we help to drive through and change and tackle, so that those people see that change as real and feel able to be engaged and empowered to help lead and be part of it. That said, that for people every day doing a job where they see one patient at a time, it can be very hard to take a systems view, and some of those things that are necessarily strategic may not always feel relevant for people. So how you involve those people in understanding and shaping those agendas and recognizing the consequences of doing or not doing those programs of work is really important. That applies equally to clinicians as it does to patients. But I guess for me, recognizing where the real problems are and using those to drive how we organize and understand our change programs is really important. Now, that might not be that those clinicians are dictating the content of those strategic change programs, but they absolutely should be telling us where the barriers are. If people don't feel permission to be able to stop doing the things that don't add value and be able to do new things, or have mechanisms to be able to identify things they want to start, it makes it very difficult for them to get engaged in change. That said, we can't have people, I guess, doing a lot of very disparate and unconnected things that don't then make sense around value or impact. And so how you're bringing people into those conversations for them to think about, what does it mean for my role today and every day? How can I then support the system to do this and think better and differently is really important. So I guess, I don't have all the answers, and I realize I'm being interviewed by two eminent big thinkers around change. But I guess for me, that involvement and engagement, that building awareness and having true clinical leadership and people with lived experience involved and engaged in decision making at a range of levels, whether that's strategic or local, feels really important. Because if people don't understand what's happening to them, then or why, they're not going to be able to want to or understand the reasons for or find the time to or the resources to do things differently. And let's be honest, to make changes happen, it requires people to feel like they've got to put some discretionary effort into doing something new, whatever scale that is. And why would you if you didn't think it was worth it? So I'm a really big believer of using the data to help drive the reasons why people need to do something differently. And ultimately, when you're thinking about things like technology, there's often resistance, and good reason for resistance about some things, but also helping people understand if we don't do something different, these are the risks. It's not risk-free sticking with the status quo. And so, for example, if you're trying to introduce, let's just say, some kind of AI intervention for dermatology assessment, and we know that, many physicians feel are worried about the efficacy of that intervention. But the risk of not introducing new technologies or doing something different means they're sitting on a lot of clinical risk in their current practice and their waiting list, missing cases, not diagnosing things, people getting, delayed. So I guess for me, the biggest part is around engagement. That all comes back down to how do we communicate and engage with people so that they feel part of things, they understand why, and then that unlocks a whole lot of set of other things that leaders need to put in place around permission and ability and incentives and levers to be able to then make people understand that. I think there's a very simple framework that the IHR use, which I always think is really helpful, which is about motivation and execution and ideas. So people need to feel like they want to and can do something differently, and they need to really know what the things are to do that change, and that they need to be able to have the method to be able to go and make the change happen. And it feels like, although that's quite simple to say, I don't always think that we consider all of those things when we're thinking about change, whether it's big scale innovation or not. I think the best health systems in the world have really nailed that. They understand that to be very important, and they drive that through the lens of the people that have the most impact to make that change, and that's clinicians and that's the service users themselves.
Great.
Dominique, a significant part of your work is focused on equity and prevention. So can you say a bit more about that? What does that involve, and what kind of impact are you seeing in these areas?
Yeah, and I think it's a really big topic. It's very pertinent at the moment with all of the things that are going on in the world geopolitically, more broadly than just health. And of course, the pandemic has revealed stark variation in health, in outcomes, in access, and what equity means to health systems, to people, to staff will vary and differ by region, by system, by the way in which the
Yep.
care is provided and delivered. But I guess it starts with the common premise of who benefits and who doesn't, and what do we think is something that we want to change. And with that in mind, then I've done a lot of work to start looking at health outcomes around waiting times, around experience. So, if patients who come into our system don't speak English in the NHS, we know that they have worse outcomes and worse experience. If you take a whole suite of patient safety measures and you look at them, like, for example, medication errors or falls, and we cut those by different equity parameters, they might be social or demographic factors, they might be geographic, they might be a whole bunch of different ways in which we want to use the equity lens to look at them. We can see huge variation. So I think the first thing to understand is what do we think is the lens of equity that we want to look through, and then trying to understand the data through that lens. And once you see those inequities, it's very hard to unsee them. The next barrier and challenge is, well, what do we do about those? And I think one of the things is about being courageous to say, we're going to have to do something different for a group of people that doesn't look the same for everyone. And that might require moving resources or additional resources for that group of people to get them to be able to benefit, or get them to have the same access or outcomes as other people have. So that's then about leadership decisions and strategic choices that become very important to people to make those. And I think what we often fail to do, particularly in healthcare, is have those courageous conversations about what are we prepared to invest in or not, and what do we really mean by this. So I've done a lot of work in terms of looking at equity of access, as I mentioned, and taking quality metrics and cutting them with an equity lens to say, well, if people aren't coming to their appointment, why not? And we realized that people, for example, had appointments arranged during pickup times for school, and they didn't have the means and ability to pay for their children to have childcare. Or we would send letters out in English saying, if you don't understand this letter, please call this phone number, and people wouldn't be able to ring the number because they couldn't read the letter. So if we're really serious about tackling inequities, we need to think about what are we doing as a system to promote those inequities, and how do we do things differently. Equity is a complex subject. It sits beyond the realms of healthcare. There are huge amounts of things that influence that around the social determinants of health, around individual behaviours, around a lot of wider things. But I think healthcare can have a role to play, and a more significant role that people would initially think about. So we try and say, well, where are the things not working and for who, and then how do we get those insights, and what do we need to do? And I think, I've done a lot in vaccine equity, vaccine uptake, in access to healthcare, all sorts of areas that lend themselves well to that kind of set of methods.
So if a leader was looking to start, we want to focus on equity, have some focus on equity. What would your advice be on how to start? You mentioned, deciding what your equity lens is. Then how would they figure that out? Or what advice would you give to someone who's really just starting off on that journey?
So I would say there's a few areas that you can look at. If you're working in a sort of healthcare delivery space, you might want to take the data that you already collect and say, what types of ways could we drill this down for? So if it's safety or errors, like how might we look at, are there particular population groups that seem to be more affected by falls or medication errors or wounds, or have we got longer waiting lists for certain groups than others? And if access is the quality measure or metric or issue you're worried about in your system, then start there. If it's patient safety, start there. Start where you already have quality issues, and those are the things that are keeping you awake, and start to look at them through the lens of equity. As I say, you might take age, you might take rural or urban, you might take a particular race, gender, ethnicity,
Yep.
you might take deprivation, income, you might take a whole range of different lenses that you can look at. You need to understand whether you actually collect the data or not. And if you don't, for example, around language or religion, then you might want to start collecting that data to understand whether you have differences and disparities. And once you then have the data, you start to say, well, how are we going to find out now? We see there's a problem and the data tells us what's causing it. And then that comes back to the conversation we were having about co-production, involving people to get those insights and then say, what is it we need to do differently to help you? So I would say start with the area of things that you already measure. Don't try and start with something new initially. Look at what you already measure, understand what you already have data to look at with an equity lens, work out if you need to then get new data, but very much you need to start thinking about how do you involve people and take them out of those boxes and make them real people, and then talk to them about the problems and understand more to have the interventions. But there are lots of health systems around the world on this journey. This isn't something people need to struggle with alone. There are places doing amazing work with a whole different model of payment and delivery systems, working at national, regional and local. Find the areas of good practice and find people who you can go to learn from, because I would say in healthcare there are no really new problems. The problem you are likely to start to be trying to tackle is not something anyone is not struggling with somewhere else. So use your networks, learn, share your methods, share your failures, share your impact, because other people will be trying to do the same thing.
Sure. So in that line, obviously collaboration, bringing people together, and healthcare is a complex system. In your experience, with that, you've got these multiple players. The NHS is a good example. You've got different players, different motivations, different drivers. How do you move from that kind of competition silo to collaboration? What kind of things have you done to help that happen?
I think culture, and it sounds a bit sort of cliched to say it, but culture is the main currency and the way in which we get things done. If you think about health and care, it's a people business. It's people delivering care to people who are receiving and co-producing it. So the way in which we behave and the way in which we organise ourselves and the way in which we set up and construct our systems is very influenced by culture. I think I do a lot of work thinking about the role of kindness in healthcare and how important it is for our interactions, whether that's with the patient, and there's huge amounts of evidence to show that outcomes do improve and increase with kindness. And it's not just about soft and fluffy saying nice things, but there's actually a whole set of behaviours that have been evidence to show that. And understanding the difference between kindness and compassion, thinking about your colleagues and putting yourself into their shoes, particularly people that you don't necessarily know well, who may work in a different part of the organisation, a different system, different region, different country, whatever it is. Building those relationships is really important, and it's hard to do that virtually. But I think that building that trust and those relationships starts with behaving how you would want to be treated. And in kindness, we talk about that as treating other people like your kin. So not everyone gets on well with their families, so it might be a bad example, but treat people how you would want your family to be treated. And that starts to unlock different ways of behaving and thinking about, well, what do we want that to be look like around here? What's the culture we're trying to foster? And then that starts to move into a place where it builds trust. And then this phrase around psychologically safe, the ability to challenge, to speak up, to behave
Sure.
and do things differently,
Yep.
and take risk. I mean, innovation and change requires us to do all of that. But I mentioned earlier in a different answer about learning. I think, some eminent leaders have told me the importance of being curious in learning, being open, and thinking that it's okay to test and fail as long as you support each other. You're very clear about what you're doing and that you know when you need to stop doing things. So all of that sort of stems back to, I think, culture and behaviors. And that's
Yep.
the most important thing when you're working across systems. We don't have much other currency often to do things well,
Yep.
but that is one thing that's in all of our control to do that.
Sure.
Okay, so as we're coming towards, the end of our conversation, I would like you kind of to step back and look forward for a moment. Putting your forecaster hat on, what is the one shift that will most fundamentally redefine how we approach population health over the next 5 to 10 years?
Wow, my crystal ball is out here. I'm going to do some predictions, but I guess I'm probably not going to say anything that's particularly, it's definitely not controversial, and I'm not sure it's hugely insightful. So I'm just really adding what I think we've already talked about, which is that we as a health system, whatever level you're working at, need to make that shift from reactive care to proactive. And I heard Don Berwick from the IHI talk about, particularly hospitals needing to stop being just repair shops and think about their role more broadly in health. That there's definitely a shift that we need to make if we're going to tackle all of the rising demand and the increasing disparities that we see in health, and how to sustain healthcare going forwards, because these models are going to become unsustainable. And to do that, we also need to make sure that we are making the best use of data and digital and real world evidence to help us understand, intervene earlier, and do that more in a precise and personalized way. But the main thing is the mindset of shifting, I think, from reactive to proactive. But technology is not going to do that alone. We need to make sure that that's as I say, a mindset, a leadership, a culture, a behavior change in how we do things. But I think how we train people, how we think about our health policy, how we manage and deliver our services is all of that needs to be thinking about what's this shift from reactive care to proactive, data enabled sort of care and prevention. I think that would be where I would suggest that we need to be focusing. But I'm biased. I've just spent a lovely 40 minutes talking about the importance of population health and public health. So of course I would say that.
Well, this is our third, episode, and again, we're very hopeful that we'll have many health leaders listening to us today. So, if every one of them acted on one idea from this conversation, what would you want that action to be?
Wow, if I had the magic wand. So I guess what we've talked about here is the intersection of the worlds in which I'm the most interested in, which is around sort of population and innovation. But they're not abstract concepts, I guess. They are practical tools for improving lives at scale. And I think if we start with the end in mind, focus on the outcomes, the equity that we're trying to improve, the collaboration and relationships we're trying to change, and design that from the start, I think thinking about starting with the end in mind is really important. And also think big, start small. I'm stealing cliches from improvement, but you can't do everything. You can't do it all at once. You've got to start somewhere, and starting somewhere is better than not starting at all. But there's so much to gain from the changes in which we need to make sure that we deliver over the next few years. I think it would be that focus on the end in mind and start somewhere. Think big, start small. That would be my probably my magic wand or
Okay.
my encouragement.
Well, that'll do it. Thank you very much, Dominique. And thank you for listening to The Pulse of Change. We hope today's conversation has sparked new thinking about population health, innovation, and leadership in complex healthcare systems. If you enjoyed this episode, please follow, subscribe, and share it with colleagues. Join us again, and we continue to explore with the people and ideas driving meaningful change in health and healthcare.
Thank you. Thanks for having
Thank you
me.
very much. This is The Pulse of Change.
Conversations that move healthcare forward.